Here's a $50,000 question. Is the patient in transition or are they over-medicated? How can you tell the difference between over-sedation from medication and the transitional state? This is often a really tough question for the hospice team. It's confusing and upsetting for patients and their loved ones. It is really important to gather as much information about the patient's symptoms and the trajectory of medication used for comfort. Sometimes you have to have this information about the patient's status and the medications used for symptom control even before they were admitted to hospice. For example, I have a patient who is quickly declining because of severe pain, and she was admitted specifically to hospice care for intractable pain in her back, right hip, and leg. And as an aside, she also had severe cardiac disease, which then also contributed to her decline. Her pain had been severe enough to cause her to stop eating, so she was losing weight and there was some starting dehydration. So we admitted her with orders for pain medications as she was being admitted to hospice. Her pain was really severe. It wasn't controlled with a particular dosage and schedule of oxycodone. So always, with the assistance of your medical provider, what we did is we adjusted the patient's schedule to see that she was getting slightly more of the oxycodone, and it was on a consistent schedule around the 24-hour clock. Remember, a smaller amount of medication on a schedule is generally more effective in controlling pain than waiting for the pain to get severe. Well, unfortunately, this wasn't particularly effective for my patient. She was asking for a lot of PRN breakthrough medications, and that caused lethargy. This bothered both her and her family. So in getting to know her and assessing her pain, we found out that she really had a lot of neuropathic pain, so we switched her to methadone. And as you might remember, in fact, watch Brenda's video specifically on methadone. It takes a full 5 days to fully reach its effectiveness for the initial dose. So during this time, needed doses of another narcotic are used to assure comfort for breakthrough pain. In this case, morphine was the breakthrough medication, and she continued to request it regularly. In fact, to the point of being continued lethargic and sleepy. She wanted so badly to be out of pain, and it sometimes just takes time to find that sweet spot. As the hospice guide, it feels frustrating, and often it's difficult to find that happy medium to provide comfort with minimal sedation. Of course, then based on the sleepiness, she had less intake, more dehydration, which then is the definition of the transitional process. So now we see a patient who's sleepy, not drinking very much, and receiving pain medication, not only because they've requested it, but staff and family have witnessed her being painful. So then family is called in, they start to come to visit based on the decline, and they question, why is this patient so sedated? And they start to question the amount of medications in use. What to do about it? Let's go back to what's so important to the patient and the family, their goals. Hopefully you have discussed this at the start of care, and this is really time to revisit the goals. What did they want related to their own care and comfort? Was their goal to be fully out of pain despite any side effects, or did they want to live as long as possible with reduced pain but be alert? This can be such a rock and a hard place, as it was for my patient yesterday. She was able to be aroused to drink, answer questions, be moved without significant discomfort, and the family really wanted to see if we could get her awake. So we wrote the order to decrease her scheduled pain medication to give her a chance to see if she'd wake up. But you know what? She awakened on her own and asked for morphine. So at that point, the family was convinced that what was important was her comfort despite the increased sleepiness. We woke her up, we made sure that was what her wishes were, and then she wanted to go back to sleep. And she even acknowledged her readiness to die. You know, these types of experiences are real dilemmas, and they require a very careful discussion with the patient, the family, and the hospice team about the ethical choices to be made. They take lots of compassion, patience, and many repeated explanations as to the plan of care and what normal transition looks like. It is not easy. Don't be afraid of talking openly, clearly, and honestly with the family. And of course, do assess your patient carefully as possible related to their current condition and how they arrived in the current state. Review with your medical provider and give your best opinion as to whether it is a true decline into a transitional state or symptoms related to over-medication. Do invite your social worker, your chaplain, help them get involved with those existential questions. And finally, be gentle with the patient and yourself. As you walk down the path with the patient and the family, every time you have one of these experiences, you'll have a little more intuitive discernment about what is happening. Consider having a case review with your team for everyone's input and to learn more after the patient dies. And know, if you're doing all these things, you are doing your very best. Thank you so much for the care you're giving. And please visit our website. Give us your questions and your comments so that we can meet your needs. This is Nancy and Brenda, the Hospice Care Queens, and our motto, care is treatment.